Good afternoon. And first, go birds. So, today we are going to continue with our series in making certain that you are successful in your journey in the first time out, successfully acquiring your CADC, your certification in substance abuse as a certified counselor in drug and alcohol. So, again, this is Double Doc, and we are going to focus on two things. The largest component in the exam, which focuses on counseling. And just as I said at the start of this series, I'm going to discuss my scores. I couldn't do it initially as I knew what my raw score was, but I was not privy to the breakdown of percentage by the four areas that are prevalent on the exam itself, but I finally got them. So we're going to break those down for you as a treat. All right, so this presentation is going to focus on the fundamental theories that are essential to the general evolution of psychology, and we are going to also include the understanding of crisis management and how that's utilized in the practice of substance abuse and recovery programming. And it's going to enable you to be fully prepared for the certified addiction counselor exam with the emphasis that is on counseling. All right. So, when you think about group, okay, there are several approaches, but you need to basically understand what the actual stages of group are. But you, as a facilitator, need to put those pieces in place so that your group can be successful. All right. And group leaders in general, those practitioners should involve the members or clients in establishing the foundation of the group norms, as it enables some sense of ownership in the group process, and understanding that as a facilitator of group will enable respect for what is actually transpiring in the group itself. You, as a practitioner, must be flexible in how that takes place, and knowing how you're going to set your group up. Is it going to be a closed group? What happens when people leave the group, if that happens abruptly, and how that can affect the momentum of the group, right? So, what do you do when people complete the group? Are there celebrations? Um, and how do they look? Within our jurisdiction, there's a set regimented process. But in typical substance abuse, there are expectations that go along with that. And we also have to be mindful that group needs to be integrated based on culture, and that aligns with the specific competency. And remember, we talked about how SAMHSA has specific competencies that align with the formulation of counseling in general. So you need to refer back to that TAP 21 that I showed in another video. Um, Also, what does it look like to be a part of the group, right? I just mentioned that a few seconds ago about inclusion. If there's a certain criterion centered around age, gender, and remember how we talked in another video about screening and what specific screening methods will be used, and where's that the group taking place. Now, I don't have the luxury that maybe you may have. That's specifically determined, by the uniform correctional staff. I've already addressed this, how when someone successfully completes, what that looks like, if that's going to be a certificate um, or not, or for some people, if that's a celebratory by a meal or something like that. But these are the elements of what group consists of. So there is also some core definitions associated with group. Now, these clearly, when you are preparing for the exam, and I've offered the notion of setting up some index cards so you can actually begin to remember these and begin to rehearse these, right? So you want to know essentially what active listening is, okay? And paraphrasing and reflecting and summarizing and validating. These are very distinct. People tend to get these mixed up, right? So when you're actively listening, it's actually going back and trying to connect the emotional aspects and or perspectives, minusing judgment, right? And trying to connect with the individual or members that are in the group itself. Paraphrasing, however, is the rephrasing of an essential message that a member is trying to convey what was said, and to expand or deepen the conversation within the group itself. So, distinctively, when you reflect, right, it's to deepen the understanding and to encourage the person to explore the experiences that they are specifically talking about. So, when you summarize, however, it's going back to the main thoughts and feelings from a specific session, right? That's a broader, a much more in-depth process than reflecting. When you validate, you're actually going along with what that person is actually conveying to you. You're legitimizing what is being said, right? Without your own personal inflection. So, my suggestion is with these specific definitions for group, you want to actually write them down, as I said, and begin to memorize them, because these will appear as multiple choice questions. And then you have the other ones with genuineness, concreteness, and empathy. There'll be multiple choice questions that will ask you, especially with, we'll talk about this in a few minutes, motivational interviewing. They'll ask you, which technique is this? You will have to be able to, a good one is sympathy, empathy, and apathy, right? When thinking about empathy, to put someone else in, to put yourself in someone else's shoes, that's the notion of empathy, right? To actually try and see it from your individual's perspective, that's the notion of empathy. Sympathy is feeling sorry for someone, so you have to be able to make those type of distinctions. Now, this is something that we've all, from our advanced degrees, we've been mindful how we need to always look out for this, because this is definitely on the test. So transference is something that can be used in the setting, right? It's always about the underlying aspects and meeting those emotional needs in treatment, right? And it happens in substance groups and or the understanding of addiction, right? And the practitioner must be aware of how this occurs and what is driving that. But we also have to be mindful of our own boundaries. And when that happens, that's countertransference, right? And it happens also because there can be a dual meaning, right? So the replacement of one addictive substance for another, that's transfer addiction. And the psychological transference, the unconscious redirect of those feelings from someone onto the practitioner. And the client themselves experiences these emotions. And they're not necessarily realistic in any way, shape, or form. And it becomes because the individual is displacing these emotions, and it's the constant redirection of those, and it's ongoing. But the practitioner must be aware of that, and it requires some dialogue surrounding it. And a skilled clinician must be able to address those in a true non-confrontational but supportive manner. And there's another aspect of knowing when to be able to say, I've taken you as far as I can take you. We may now want to take a look at moving to another individual to propel you forward in your next level of your journey in recovery. So now we're going to move towards the actual stages of group. Now, in the psychological realm, the stages of group were originally offered by Tuckman, right? And it was originated how group goes from 5 stages from production, right? So forming, those were the initial introductions. Storming, right, when conflict arises. Norming, that's that cooperation when we're starting to get to know each other. Performing, when there's high productivity and things are starting to jive well. And then adjourning, and there's that disbandment of the group through completion of itself, right? So the same applies in group work around recovery and substance abuse. We get to think about what it is that we're here to do, right? And in that aspect, we're trying to establish through the facilitation aspect, group leaders, rules and norms. That's associated with competency 90. Remember that tab 21, that SAMHSA that we discussed earlier. Now we're trying to explore, and the members who are in the group kind of talk about what got them to this time and space and needing to be in treatment. That's competency 91. And now we're working together, right? Members are trying to get that plan and see how they can all work toward that drug-free lifestyle in of itself. And then they can gain insight. And that's one of the benefits of doing group work in recovery, that peer support. That's what keeps that momentum going and that motivation. And it's an importance about relapse prevention. You will find that on the test as well. That's a constant, ongoing question in multiple forms. Storming. Now, there's that determination of how to work cohesively, and problem solving will come up, right? And then that norming, right? There's providing some competent, supportive information through that sharing of their stories. And this is when another layer comes in through other external supports like Narcotics Anonymous and AA. And that's also brought up through other types of questions, and we'll cover that later. But the stages of group are definitely going to be constant throughout that test in this particular area. This particular theory, CBT, was very frequent throughout the test. Cognitive behavioral therapy, and it's about the harmful thinking and negative aspects that are learned through maladaptive coping mechanisms, right? What you think, you will act on. And it focuses on the here and now as opposed to the past, and that exploration of those thoughts that lead to the self-destruction patterns that impact one being clean and sober. All right. And there's also another aspect about contingency management and how positive reinforcement is an aspect of increasing the frequency of a certain type of behavior, right? So in a program, right, if there's an aspect of random urine drug screens, and you know that there'll be some positive praise surrounding those who submit negative drug screens, then it's more likely that a person will continue to be clean and sober if they know that that is an intervention that's going to be used, and they'll continue to get that positive praise, right? So the bottom line is, if you utilize this as a methodology, excuse me, as a methodology, it is a excuse me, it is a aspect that the more likely that there's a positive natural reinforcement that a person will continue to utilize a positive behavior, and it will decrease the likelihood of engaging in negative behavior because it one will begin to think in that positive direction. This particular methodology was originated by Aaron Beck. So CBT is a very powerful methodology, and again, it was noted heavily in that exam. Now, the benefits, very, very goal oriented. Um, it's most effective because it helps people focus on the cravings, management of stressors, and understanding of triggers. Because if you understand what can trigger you, you know how to better prepare if you're exposed to that stimuli. It's very powerful in utilization with group work. There's a collaborative element to it in regards to the negative patterns and thought processes, and it can be utilized in everyday life. Now, here's the one that I will earnestly say, if I had to pinpoint which theoretical construct that I saw the most, as I said, CBT was mentioned a lot, but this probably motivational interviewing was asked the most. If you don't remember anything, rolling with resistance and ambivalence. It is an approach where the therapist or counselor or psychologist empowers, supports the individual in maintaining their sobriety in that manner. It is very non-confrontational. It focuses on treatment on those areas by utilizing that approach. It was originated by Milner and Rolnick, and in the 1980s. It is alliance based, fueled by collaboration. It is goal directed by the individual themselves, and again, rolling with resistance. One of the actual benefits, it improves retention rates. There is very, very, very high probability of the decreasing of relapse centered around motivational interviewing because of the fact that the individual is guiding the treatment it's themselves. But again, remember, rolling with resistance, that will be, and ambivalence is something that you will continue to see throughout the test. There was one question that I can remember in regards for REBT. It is similar to CBT, but it is more directive. It was originated by Albert Ellis. It is slightly more, like I said, confrontational, and it is more directive. Again, it is focusing on negative cognitions, which again are thoughts, focusing on emotional distress and self-defeating behaviors and belief systems, and those faulty, irrational notions that are based to get people to more be logically based. Again, it's more directive, and the connection is about thoughts, feelings, and behaviors being interconnected. Remember when I said earlier, if you think it, you definitely will act on it. So the goal is to reformulate that thought process so people will move in a more positive direction. Family systems. This was heavily saturated as well, to understand how the family plays a role in the recovery process. If you can understand that, then there's a more likelihood that there's going to be a success rate in recovery. But the opposing side is to see the core function of how unhealthy family systems can actually be enabling in addiction patterns. It is the cornerstone of family therapy. Their family oftentimes can be the generational impact of addiction. There are interconnections within the family system, as I said, that can impact recovery. Birth order is a impact as well, and attachment is something that can perpetuate addiction styles as well. Um, but the key aspect is how communication can also prohibit successful recovery patterns. Please understand, family systems was heavy, and also there's another section that this will be profound in, and that's the case management aspect. Um, Enabling. It can be unintentional, especially within the family system, because people are not necessarily aware that they're doing it. But one of the benefits, a major aspect, is providing a safe space for family members to address the traumas and emotional aspect related to addiction. And there can be both an individual and collective recovery, right? And there's the aspect of treatment planning that engage the family in the treatment planning process, because you want to know how the family can support the person in recovery in meeting their goals. If there's ever someone who says, yes, my aunt, my mother, my father, whomever, you want to engage them, because that is an important integral aspect to success. That is definitely on the test. Okay, psychodynamics. Or psychoanalytic. We've heard it before, Freudian concepts. I can earnestly say this was one I do not recall being on a test, but we want to be prepared. Better to have it than and not need it than to need it and not have it. So there's the notion that there's unresolved conflicts, and substances serve as a maladaptive way to manage uneasy emotions. That's the cornerstone of psychodynamics. And this is a way of self-medication, and that's what substance use and abuse is about. Three elements. We've heard this, right? Id, ego, and superego, and that's the conflict amongst the three. And utilization of the substance provides momentary relief, right? The relief is caused by emotional pain, anxiety, trauma, and or grief and loss, right? Um, another key aspect is to understand how the defense mechanisms play a key role. And those aspects would be denial, rationalization, and avoidance. And they are used to cope with the negative emotions in addiction. Okay, so that's the key tenets that are associated with psychoanalytic counseling. What I suggest again is to create index cards and to define denial, rationalization, and avoidance. All right, that will be helpful for you. Now, the major benefit about psychoanalytic is to understand the factors that trigger relapse, being self-aware, right? And ideally, reduction of impulsivity and resolving the conflicts over time, and then those unconscious motivation are are revealed, right? And that surface exploration, that free association, dream analysis, and being mindful of transference, key elements. Again, that transference comes up, so that's something else that you definitely want to create an index card and make sure that you're clear on what it is. Gestalt theory. Now, Gestalt is dealing with the whole person, right? That's what the bottom line of Gestalt theory. I can honestly say I don't recall this being on the exam at all, but again, we're gonna cover it. Patient and therapist, most important aspect of this modality. Use of acceptance and warmth, right? So this key relationship can definitely impact success. Okay, it focuses on the here and now. There's very little focus on trying to block someone from encountering an unpleasant experience, but exploring where that negativity is stemming from, um, and and looking at the negativity and past concerns, especially trauma. Right? You definitely want to look at responsibility for the thoughts, feelings, and actions. And the clinician is responsible for the expression of empathy. There's a true necessity for the therapeutic, creating a positive therapeutic relationship. And there's a technique you definitely want to understand clearly, the empty chair technique. And that is used for people who cannot be present in a session. It's essentially talking to the person, having a chair present, and you then would actually have that conversation as if the person was there. Now, the benefits is the root causes of what prompts substance abuse, understanding emotional regulation, and then fully understanding what that experience and how those feelings limit them in general, and how substances actually serve as a coping mechanism. And then rebuilding the aspects of esteem, right? And then helping someone understand how they need to take accountability and responsibility for their actions, right? And people tend to isolate, right? But the goal is to get people aligned within community supports and feel connected and less isolated throughout this recovery journey. Okay? Gestalt theory does help with those aspects. Now, solution focus. Solution focus really is a brief intervention, right? But the key is, what would life look like if? And that's the miracle question, right? And the number of sessions is based on client need, right? So there's no prescriptive number, but typically it's less than 5, but goes typically no more than 10. But again, it's based on need, right? And it's about what's typically realistic for the individual, right? And it's about a sense of empowerment. So it's unlike some other theories, which the number of sessions are very, very lengthy in time frame. This is a much smaller window. Okay, so it's much briefer. Now, in working within, and this was on the exam, understanding what the harm reduction model is about and why it's essential. Sometimes there are people who say, well, my goal may not necessarily be abstinence. My goal may just be reduction, right? We have to accept that, because it's not our journey, it's the person who's in treatment, their journey. The practitioner relationship in this modality is extremely important because the person is in recovery. So we have to accept their choice, right? And this particular modality is, we have to be sensitive to that, because this is truly about behavioral change. So if their behavioral change is, if they're drinking, let's say, 25 days out of the month, and their goal is to drink 10, well, that is great. That is a reduction, right? It's about safety, okay? And it's about health, and it's really about what their need is. Some examples, right? Other options are MAT, medication assisted treatment, the needle exchanges, fentanyl testing, right? The use of CBD, naloxone, right? And there are other aspects too, other health related aspects. There could be if people are engaging in utilizing other substances, and let's say not practicing safe sex, it could be getting them safe sex education. All of these things are important because it's about safety, right? So all of these notions need to be understood. Okay, there's this connection about how there's overlap. All of these aspects, transmitted diseases, HIV, hepatitis B and C, it can happen because of what? Through the sharing of needles. It places one at an area of increased vulnerability due to the factor of the risky behaviors, right? And then, as I just said, the STIs, tuberculosis is transmitted through the sharing of drug paraphernalia. So we need to be mindful and share whatever health education we can, because it's in alignment with the notion of health status. This was on the test. As I mentioned about the stages of change, this is the trans theoretical model, all of the stages of change here. And when you do your screening and assessment, one thing that I am mindful of doing is identifying when I'm doing those screenings, I will try to indicate what stage of change someone is in based on what their answers are, and then kind of go back and forth just to get more information if someone is willing to receive treatment. But the key is, this model is not linear. It's not a linear model. People can skip stages, revisit them, go back based on a relapse. And we have to be accepting of the fact that relapse is part of recovery. And it's something that doesn't mean failure, but just that we need to understand what prompted it. And there's something else, relapse and lapse, and knowing the distinction between those two, that was on the test itself. Okay. Then there's crisis management. You do have to know the difference between crisis prevention and intervention, and what it means between those two, and how to support someone in that distinction, what that means based on your state, what you need to do as a practitioner, counselor, when to seek support, um, knowing your mental health laws, and how to assess for a crisis, and safety, when you need to warn others, when you need to seek supervision in regards to crisis management, when a crisis is over, and what other supports need to be put in place. Okay, so that's the distinction. And knowing when your limitations, and how then to pass that off to someone else, for additional layers of support for the individual who is in crisis. Okay. If you have any questions about anything that was discussed, you can post them in the comment section, and I'll definitely will respond. So we can be successful, and you will be successful with your first time in completing your CADC. So, as I said, I will briefly go over what it looks like. So here is what the CADC completion looks like. I don't know if you all can see this too. I was trying to get it so you can see that that's the CADC symbol, and I don't know if you can see it, but so you get 4 areas that you get scored in, and they are scientific principles of substance use and co-occurring disorders, evidence-based screening and assessment, evidence-based treatment, counseling and referral, professional, ethical, and legal responsibilities. So as I had mentioned at the first video, the maximum score you can get is 800. A passing score is 500, and I got a 694. Interestingly, uh, I don't know. At that time, I didn't know what the percentages were. My highest percentage was in evidence-based treatment counseling and referral. And that's what I thought I would be because of what the nature I would do. That was 90%. Um, I was surprised at the scientific principles of substance use and co-occurring disorders. I got a 70%. The evidence-based screening and assessment, I got an 85%. And the professional, ethical, and legal responsibilities, I got an 87%. So there you have it. Those are my scores. But it's a pass. So if you have any questions, please let me know. Again, this is Double Doc. We'll continue to keep plugging forward, and I will post some definitions. I think I'll type those so you can maybe create some flashcards based upon those actual terms. If you need me, I'm here. Thank you so much, and have an amazing day.